Start now. Good
Yes, please.
afternoon, everybody. So today's RDLS session topic is prophylaxis for opportunistic infections in children. Today's speaker is Dr. Malabika Maity. She completed her MD in Pediatric Medicine from Medical College and Hospital, Kolkata. She completed her DRNB from Delhi in Pediatric Cardiology from Fortis Esports. And currently she is working as RMO cum clinical tutor in the Department of Pediatric Medicine of Medical College and Hospital, Kolkata. Now, I request Dr. Malabika Maity ma'am to enlighten us on today's session. Thank you.
Thank you. Today I'll be discussing opportunistic infections in HIV. Globally, opportunistic infections are the leading causes of morbidity and mortality among HIV-infected children, contributing to more than 90% of HIV-related deaths. Children living with HIV are susceptible to infection with multitude of opportunistic microorganisms, including protozoa, fungi, viruses, and bacteria. Immature immune system coupled with lack of prior exposure to these organisms in these children further increases the susceptibility for these infections. In contrast to HIV-infected adults, the correlation between CD4 cell status and opportunistic infection is poor in children. Treatment and prevention of opportunistic infection is important component of comprehensive care of child living with HIV. Prevention of common childhood infections other than opportunistic infections, which can be life-threatening in these children, is an additional challenge. Since opportunistic events tend to recur, prophylaxis needs to be continually given regardless of any previous successful treatment. This is the table showing CD4 cell count and the opportunistic infection at which CD4 count, which infections will occur. There is a correlation between occurrence of opportunistic infection and CD4 count. CD4 count जैसे कम होता जाता है, किसी लाइफ थ्रेटनिंग इन्फेक्शन HIV के साथ होता है. Therefore, early identification of symptoms and adherence to appropriate treatment are extremely important. So, what are the treatment are given? For pneumocystis carinii pneumonia, cotrimoxazole is given. To prevent tuberculosis, isoniazid is given. To prevent cryptococcal infection, if cryptococcal antigen test is not available, in case of CD4 count less than 100, fluconazole is given. To prevent recurrence also, same treatment is given. What is primary prophylaxis? Primary prophylaxis is prophylaxis given before the appearance of opportunistic infection. Secondary prophylaxis, this is given after successful completion of treatment of opportunistic infection. It is called secondary prophylaxis. What is cotrimoxazole prophylaxis therapy? Cotrimoxazole prophylaxis is an effective proven strategy for reducing morbidity and mortality in children with HIV. It not only protects the infants and children from pneumocystis jirovecii, but also from malaria, diarrhea due to isospora, cyclospora, toxoplasmosis, and other bacterial diseases. All HIV-exposed infants should get to cotrimoxazole prophylaxis from the age of 6 weeks until HIV is reliably excluded. In all those confirmed to be HIV infected, CPT should be continued till 5 years of age. And the dose is 5 mg per kg per day of trimethoprim, sulfamethoxazole as a single daily dose. In HIV-exposed or infected infants for children, all HIV-exposed infants for children from 6 weeks of age, it is given at first encounter of health services. HIV infection has been reliably excluded by a negative antibody test at 18 months, regardless of ART initiation. All HIV-infected infants and children up to 5 years of age, in this case, regardless of WHO stage and CD4 count at 5 years of age, then it is to discontinue when the clinical immunological indicators confirm restoration of the immune system for more than 6 months. In a child more than 5 years of age with a WHO T stage of 1 and 2 and CD4 count more than 350 cells. जैसे बच्चा का CD4 count more than 350 हुआ और stage 1-2 हुआ, तब ये बंद कर सकते हैं. And it will be tested 2 occasions, not less than 6 months apart. All HIV infected children more than 5 years of age WHO stages 3 and 4 regardless of CD4 count, or CD4 count less than 350 regardless of WHO staging. When clinical immunological indicators confirm restoration of immune system, then we can discontinue for more than 6 months in a child with more than 5 years of age with WHO T stage 1 and 2 and CD4 count more than 350 cells on 2 occasions. As secondary prophylaxis, after treatment of completion of pneumocystis carinii pneumonia, less than 5 years of old, we will not stop this drug, and more than 5 years of old, with a WHO T stage 1, 2 and CD4 count more than 350 on 2 occasions, not less than 6 months apart, we can stop. So when to start CPT in relation to initiating ART? Start cotrimoxazole prophylaxis first, then start ART after starting cotrimoxazole, or as soon as CPT is tolerated. The patient has completed preparedness phase. Then only start ART. What is the contraindication? CPT should not be started on a severe adverse reaction if any grade 4 reaction to cotrimoxazole or other sulfur drugs in these children. Children with GCSPT deficiency. Alternative drug is Dapsone, which is given 2 mg per kg once daily, not to exceed 100 mg per day. But many children may be sensitive to Dapsone also. In case of cotrimoxazole desensitization, how we do? Cotrimoxazole desensitization has been shown to be successful and safe in 70% children with previous mild to moderate hypersensitivity. If the patient reports a history of hypersensitivity to sulfur-containing drugs, desensitization regimen should be attempted only in a hospital setting. Desensitization should not be attempted in individuals with a history of severe cotrimoxazole or sulfonamide reaction. Desensitization नहीं अटेम्प्ट करना चाहिए वो सब बच्चों के लिए जो जिनका बहुत ज्यादा रिएक्शन हुआ कोट्राइमोक्साजोल में और सल्फोनामाइड ड्रग में कोई रिएक्शन है बच्चा का एलर्जी है. Desensitization can be attempted 2 weeks after a non-severe cotrimoxazole reaction that has resulted in a temporary interruption of CPT. If any reaction occurs, desensitization regimen should be stopped. Once the patient recovers fully, Dapsone at a dosage of 100 mg per day shall be tried. This is the desensitization doses. Day 1, 2 ml oral suspension is given. Day 2, 4 ml. Day 3, 6 ml, like this. Gradually, the dose is increased, and whenever there is increased reaction, the drug should be stopped and Dapsone should be started. What is INH preventive therapy? Isoniazid preventive therapy is given for tuberculosis, latent tuberculosis infection. Isoniazid is one of the most effective bactericidal anti-TB drugs that protect against progression of latent TB infection to active disease, protection against endogenous reactivation of the tuberculosis. It also prevents TB reinfection post-exposure to an open case of TB, protection against exogenous reinfection and superinfection or nosocomial transmission. The effects of isoniazid prophylaxis therapy augment the effectiveness of ART also in reducing the incidence of tuberculosis. With the concomitant administration of both ART and IPT, there is a likelihood of restoration of the TB-specific immunity by ART, and the beneficial effect of IPT is likely to be prolonged. IPT does not promote isoniazid resistance. IPT लेने से isoniazid में कोई resistance नहीं होता है. In latent TB, Mycobacterium tuberculosis bacilli are fewer in number and are dividing slowly, resulting in an extremely low risk of selecting drug-resistant mutants. Who are eligible for IPT? All children living with HIV more than 12 months of age and 4A screening negative, that is current cough, fever, poor weight gain, night sweat, history of contact with tuberculosis, all are negative. They are unlikely to have active TB. Children with no contraindication as listed in the next slide. IPT is not an emergency intervention, so if there is any doubt regarding TB status of the patient, IPT should be delayed. So, ruling out active TB is essential before initiating IPT. Children living with HIV who do not report current cough, fever, poor weight gain, or history of contact with TB, that is 4 symptoms negative, they are unlikely to have active TB. Additional investigation like chest X-ray, tuberculosis skin test can help in ruling out active TB but are not mandatory. Contraindications are IPT, active TB disease, active hepatitis, किसी को अगर active TB है, active jaundice है, signs and symptoms of peripheral neuropathy, nerve का कोई disease है, like persistent tingling, numbness, burning sensation in the limbs, regular and heavy alcohol consumption and symptoms of peripheral neuropathy, concurrent use of other hepatotoxic medication, contact with MDR TB के साथ कोई contact हुआ, patient living with HIV who have completed MDR TB treatment, इन लोगों के लिए ये IPT contraindicated है. So what is the IPT workup? Evaluate for signs of liver disease, jaundice, tenderness in the right upper quadrant of the abdomen, assess for peripheral neuropathy, that is persistent numbness and burning sensation in hands and feet, हाथ पैर में कोई जलन है, कोई नास लग रहा है कि उसमें साड़ नहीं है, whenever available, routine liver function test or ALT should be performed. But lack of ALT or ALT results should not delay the initiation of IPT in asymptomatic patients. If the patient does not have any abnormality based on the assessment above, assess for adherence to the therapy. IPT should be considered in both on-ART and pre-ART patients. If found 4S negative, and IPT should be initiated if not contraindicated. If IPT must be used in conjunction with antiretroviral therapy, a rational approach would be to start IPT after completion about 3 months of antiretroviral therapy. That is called delayed IPT treatment. IPT drugs must be provided on a monthly basis, 30 days, to all eligible patients. And the dose is below 5 kg, half tablet, and like this table. For adult and adolescent, isoniazid dose is 300 mg and pyridoxine 50 mg B6, vitamin B6, that is added to the isoniazid prophylaxis per day for 6 months. Monitor adherence to IPT. 4S screening should be done for all patients living with HIV on IPT during every visit to exclude active tuberculosis. हर विजिट में पेशेंट को देखना है कि एक्टिव ट्यूबरकुलोसिस का कोई साइन सिम्टम है कि नहीं. अगर है तो पेशेंट को INH प्रोफाइलैक्सिस नहीं, पूरा टीबी का ट्रीटमेंट ही देना है. Patient living with HIV who are 13 years of age and older, INH and rifampicin daily for 28 days is given. And that time dose modification of dolutegravir is not required. These are the current scenario where patients previously treated for TB secondary prophylaxis, all patients living with HIV who had successfully completed treatment for TB disease earlier should receive INH for 6 months. That is, the patients having past history of tuberculosis. All patients living with HIV who had just completed successful treatment for TB should receive INH for additional 6 months. IPT with ART, secondary prophylaxis. Combined use of IPT with ART is recommended for all children living with HIV, regardless of degree of immunosuppression, previous treatment for TB, pregnancy. ART should not be delayed while starting or completing a course of IPT. If IPT, what will be the IPT in children born to microbiologically confirmed tuberculosis mothers? If a baby is born to microbiologically confirmed TB, माँ को अगर TB है, assess the newborn for active TB. बच्चा को देखना है कि एक्टिव टीबी है कि नहीं है. नॉन स्पेसिफिक फीचर सजेस्टिव न्यूनेटल टीबी, बच्चे को बुखार होगा, बर्थ वेट बहुत कम होगा, हेपेटोस्प्लेनोमेगाली होगा, इरिटेबिलिटी, फीडिंग इंटॉलरेंस रहेगा. If the child has none of the above, give IPT for 6 months. Then IPT can be given for 6 months. Patient on IPT develop TB during IPT treatment. If a patient develop TB symptoms during IPT treatment, evaluate the patient for TB and conduct DST. Based on the TST results, the appropriate treatment should be provided. If the patient is sensitive to all the drugs, then provide standard AT treatment, 2 HRJD plus 4 HRE. If the patient is found to be DRTB, then refer patient to the DRTB center. Patient develop TB after IPT treatment. Treat the TB episode as per RNTCP guideline and rifampicin resistance pattern whenever available. If the patient is sensitive to all the drugs, then provide the patient with standard ATD, 2 HRJD plus 4 HRE. If the patient is found to be MDR-TB, then refer the patient to DRTB center. If a patient had taken IPT for less than 1 month in total and discontinued for any reason, like toxicity or loss to follow-up, conduct adherence counseling, address reasons for discontinuation, if asymptomatic, restart INH afresh. Ensure that they have completed a 6 months course. After taking IPT for more than 1 month, if the patient discontinue IPT for less than 3 months, then conduct adherence counseling, conduct ICF if asymptomatic restart INH, ensure they complete 6 months course within a 9-month total period. After taking IPT for more than 1 month, if patient discontinued for 3 months and above, then do not reinitiate the IPT. Now coming to the cryptococcal meningitis, that is common in patients with CD4 count less than 200. Cryptococcal disease is an opportunistic fungal infection that occurs primarily among people who have advanced disease, HIV, and important cause of morbidity and mortality. Most common presentation of cryptococcal disease is cryptococcal meningitis or meningoencephalitis, which accounts for an estimated 15% of all AIDS-related deaths globally. Mortality for cryptococcal meningitis is highest in developing low-income countries, accounting for 70 to 80% low-income versus only 20 to 30% in high-income countries. Major reason of high mortality is delay in diagnosis and largely because of limited access to lumbar puncture and rapid diagnostic assay. Antigen detection for antigen detection, serum CSF is needed, microscopy CSF, culture CSF. Cryptococcal antigen test screening for patient living with HIV should be kept at CD4 less than 200 as already discussed. Till the time cryptococcal antigen test is not available, fluconazole primary prophylaxis should be given to all those patients with CD4 less than 100. Less than 100 CD4 होने से cryptococcal antigen test के लिए हम लोग wait नहीं करेंगे, fluconazole primary prophylaxis start करेंगे. Screening is not recommended for children below 10 years given the low incidence of cryptococcal meningitis at this age. Use of cryptococcal antigen test and eligibility criteria. It has been documented that cryptococcal antigen test is reliable, robust, and easy to perform and should be used to diagnose cryptococcal infection among patients living with HIV. It is recommended to use it any patient living with HIV in CD4 count below 200 cells per cubic millimeter. If the patient is symptomatic, treat for cryptococcal meningitis. If asymptomatic, preemptive treatment is given. If the patient is symptomatic, consider evaluating for other causes. If asymptomatic, standard package of care. If patient is symptomatic, consider evaluating for TB, cryptococcal meningitis, bacterial meningitis. May consider presumptive treatment for cryptococcal meningitis and bacterial meningitis based on symptoms or reports. If asymptomatic, fluconazole primary prophylaxis should be given. So what is preemptive treatment? Preemptive treatment is antifungal treatment if asymptomatic patient living with HIV positive for cryptococcal antigen test. Everyone testing positive for serum or plasma or whole blood cryptococcal antigen during screening should be carefully evaluated for signs symptoms of meningitis to exclude active cryptococcal meningitis before initiating any preemptive treatment. In induction phase, fluconazole 800 mg per day for adult and 12 mg per kg per day for adolescent for 2 weeks is given. And in consolidation phase, fluconazole 800 mg daily for adults and 6 to 12 mg per kg per day for children and adolescent up to maximum 800 mg daily for 8 weeks. So the induction phase is 2 weeks and consolidation phase is 8 weeks. And maintenance phase, fluconazole 6 mg per kg per day in children and adolescent until evidence of immune reconstitution is there. What is the criteria for discontinuing fluconazole treatment? Maintenance treatment should take into consideration all the following. Person is adherent to ART and free of cryptococcal disease. Fluconazole maintenance treatment given for at least 1 year and CD4 cell count rise up to 100 cells per cubic millimeter and suppress plasma viral load. That is viral load less than 1000 copies per ml. In case cryptococcal antigen test is not available, primary prophylaxis must be given to HIV positive adult and adolescent who have CD4 cell count less than 100 as already we have discussed. The recommended doses shall be fluconazole 100 mg OD and criteria for discontinuing fluconazole primary prophylaxis should take into consideration all the following criteria. Person is adherent to ART, free of cryptococcal disease, fluconazole given for at least 1 year, CD4 cell count more than 100 and suppress viral load less than 1000. Preventing vaccine preventable diseases in HIV infected children. Vaccines are extremely effective in primary prevention tool for common life-threatening childhood infection in children. Vaccines that protect against 11 diseases are included in National Immunization Schedule by Government of India for routine use of children and adolescents in India. Apart from these vaccines, many optional vaccines also to be considered on case-to-case basis. Immunization and vitamin A supplementation. HIV exposed infants, like all other infants, should be given BCG at birth If BCG has not been given at birth, it should not be given in symptomatic HIV, older infants and children. Live vaccine should be avoided in all severely immunocompromised infants, that is CD4 count less than 1500, or in the range of severe immunodeficiency for older children. Vitamin A supplementation should be given as per the national immunization schedule. Rotavirus vaccine is recommended for use in HIV-exposed infant due to their vulnerability to diarrhea. Japanese encephalitis vaccine is inactivated and found to be safe for use. Check for seroconversion and give booster as required, primarily for hepatitis B and hepatitis A. Additional optional vaccines should be given depending on the case-to-case basis. This is the table showing the vaccine schedule. HIV-infected children are susceptible to many opportunistic infections. Treatment and prevention of opportunistic infection is an important component of comprehensive care of child living with HIV. For chemoprophylaxis, primary and secondary prophylaxis are there. Cotrimoxazole preventive therapy, TB preventive therapy, eligibility, contraindications, and revised TPT guidelines and IPT in specific scenario. Primary and secondary prophylaxis for cryptococcosis and vaccine preventable disease and national immunization schedule. Thank you.
Thank you so much, ma'am. Any questions from the participants? किसी के कोई सवाल है? आप अनम्यूट कर सकते हैं माइक और सवाल पूछ सकते हैं या फिर चैट बॉक्स में भी लिख सकते हैं. Any questions on CPT, IPT? Thank you so much, ma'am. I don't think there are any questions.
Thank you,
Yeah,
ma'am.
thank you so much, ma'am, for facilitating this session. Thank you to all the participants for patient listening. We'll conclude the session now.